Hi, and welcome to the next lecture, which is Lecture 6, Non-Cancer Pain Management in the Pharmacist's Role in New Pain Guideline Era. And so, once again, there's the disclosure statement. But what we're going to talk about today, if you had the opportunity a couple years ago, I know at the Value Drug Show, we had Dr. Joseph Hanlon in who gave a good talk on pain from a pharmacotherapy standpoint. And we're going to highlight pharmacology today. But one of the key things we're going to talk about in this lecture is really looking at how does the pharmacist play a role in helping with pain management. And I know that every one of you has to deal with this every day, wanting to make sure we're treating the patients who really truly do need pain medications, but in the realm of the way that's going on in our society here in the United States with the abuse factors going on, what's happening. And we're going to talk about the key principles that the CDC published for prescribers just a few years ago for new non-cancer pain. We're going to talk a little bit about pharmacotherapy and the treatment. And then we're going to talk about, what can we do as our role as pharmacists. So the first thing I want to talk about is the CDC's guidelines that they published. And the purpose of this publication was primarily to family medicine providers, internal medicine providers, physician, nurse practitioners, and physician assistants, anybody that has the power to prescribe and has a DEA license to prescribe opioids. It's also focusing mainly on adult patients and focusing on patients that we're treating pain that's longer than 3 months or past the time of normal tissue healing, which is on average anywhere from 6 weeks and shorter. Focusing more on the outpatient setting, and this does not include at all cancer treatment, palliative care, and end-of-life care, nor does this lecture. They also graded when they outlined this, they looked at the evidence-based medicine. They had different committees that went about in reviewing this and did this very similar to a lot of other guidelines the CDC has published. They came up with 12 recommendations, and we're going to review and highlight those recommendations, and they're grouped into 3 conceptual areas. First, determining when to initiate or continue opioids for chronic pain. Opioid selection, dosage, duration, follow-up, and discontinuation. Assessing risk and addressing harms of opioid use. So, let us begin. Let's determine what do the guidelines say when to initiate or continue opioids for chronic pain. The first recommendation says non-pharmacological therapy and non-opioid pharmacological therapy are preferred for chronic pain. And we'll talk about some of those a little bit later, but we're thinking about NSAIDs, thinking about cold compresses, heat compresses, good old-fashioned rest. And clinicians should consider opioid therapy only if expected benefits for both pain and function are anticipated to outweigh the risk to the patient. If opioids are used, they should be used in combination with non-pharmacological therapy and non-opioid pharmacological therapy with the goal to eventually remove the opioid as part of therapy. So what are our non-opioid pharmacological therapies? Well, we've got acetaminophen, we've got NSAIDs, we've got gabapentin, pregabalin, tricyclic antidepressants, and topical agents. These agents can be used for various different conditions. We'll go into a little bit more detail about these later in the talk, and where do those roles play? When we assess the benefits of opioid therapy, you want to assess that your patient's pain and function regularly, that a 30% improvement in pain and function is considered clinically meaningful. So you want to, the prescriber, and I could see us as pharmacists, if we were in some type of collaborative practice or we're just doing our own counseling education, discussing these goals too. All right. And so some of the questions should be asked. What number best describes your pain on average in the past week? Using that traditional scale 0 to 10, where 10 being as worst pain as you can possibly imagine to 0. And then the ultimate goal is to try to get that pain scale down below 5. What number best describes how during the past week pain has interfered with your enjoyment of life? What number best describes how long in the past week pain has interfered with your general activity? If the patient does not have a 30% improvement in pain and function, consider reducing the dose or tapering and discontinuing the opioid. Continue opioids only as a careful decision by the prescriber and the patient when improvements in both pain and function outweigh the harms. Recommendation 2. Before starting an opioid therapy for chronic pain, clinicians should establish treatment goals with all patients, including realistic goals for pain and function, and should consider how therapy will be discontinued if benefits do not outweigh risk. So this conversation should start at the very beginning. Clinicians should continue opioid therapy only if there's clinical meaningful improvement in pain and function that outweigh the risk to patient safety. So, the establishment and measurement of progress toward goals. Before any opioid therapy is initiated, determine how effectiveness will be evaluated, establish those treatment goals so that Likert scale, those pain questions, and discussion of what are those goals. And also probably discuss them in the past. How have they worked through pain? What have they done prior to this in pain? Before starting and periodically during opioid therapy, clinicians should discuss with patients known risk and realistic benefits of opioid therapy and the patient and clinician's responsibilities for managing. So being straightforward and open, understand this. This is in the news every day. People have loved ones they've experienced that have maybe lost their life to opioid abuse. Some people may be hesitant to use them all, and people may be readily to use them. And the clinician needs to be opening up why this is important. Be explicit and realistic about expected benefits. Emphasize goal of improvement in pain and function. And discuss serious and common adverse effects. Increased risks of overdose at higher dosages. When opioids are taken with other drugs or combinations such as benzodiazepines. Let them know that this is going to be periodically reassessed. Let them also know that it's a good idea to develop a pain contract. Good physicians have developed these pain contracts, which to let them know, and if you guys are aware and have followed the regulations in our state, that we need to be checking that PDMP pretty much almost every time, and physicians need to be doing the same. A good pain program also will be doing random urine checks. I know our local physician that we deal with in the area, when he did his first pain contract several years ago, I think in that very first day, he kicked 20 people out of his practice. And so that they're aware of this, and also that they're open up, while you open up at the beginning of this, is not that it's trying to make you sound like you're criminal, but this is designed, unfortunately, because of the people of the past, and just to let them know that and be aware of that. Opioid selection, dosage, duration, follow-up, and discontinuation. Recommendation 4 says, when starting an opioid therapy for chronic pain, clinicians should prescribe immediate release opioids instead of extended release long-acting opioids. This is general pharmacology, that long-acting opioids should not be exposed to naive patients on opioids. And, the other one that's long-acting that's not technically an extended release form is methadone. Methadone can have a half-life around 33 hours in some patients. Only providers familiar with methadone's unique risk and who are prepared to educate and closely monitor their patients could consider prescribing it for pain. Methadone, before we had a lot of our more fancier extended release product, was used due to its long half-life. The problem with methadone is because it's long half-life, we know all the risks that go along with that. And then the other problem is that methadone, in the past was used because it was cheap, but most opioids, the way they are priced, are not. The other one is only consider prescribing transdermal fentanyl patches if familiar with the dosing and absorption properties and prepared to educate patients about this. One of the things, too, is if look at every box of a fentanyl patch is for fentanyl naive. And I have a case at the end here to share with you about when we were trying to convert somebody back off a fentanyl patch. And it's astounding to be realistic, see how much morphine milligram equivalence is in a fentanyl patch. And then the other problem that you have is if a patient has very low fat on them, that if they don't have a good place to apply it from a dermal standpoint, it is not going to get absorbed. And then vice versa. If a person's having toxicities, even though you rip off that patch, there still may be drug in their system, and it's hard to determine how long it will be in that system. Recommendation 5. When opioids are started, clinicians should prescribe the lowest effective dosage. Clinicians should use caution when prescribing opioids at any dosage, should carefully reassess evidence of individual benefits and risks. And when we think about acute treatment, when we start going above 50 morphine milligram equivalents, this should be a warning sign. And there's significant risk of overdose when we're approaching 90 morphine milligram equivalents a day. And remember, in the past, when we talk about treating a cancer pain, there is a question: you treat until the pain is relieved, and that was the old principle. However, in non-cancer patients, we should be cautious, and when we start approaching this, we should be reassessing non-pharmacological approaches. How much benefit are they getting from this opioid? And there's some suggestion: the higher the dose, sometimes they become less sensitive to the agent. And so all of these clinical considerations have to be considered. Start low and go slow, just like in geriatrics. Start with the lowest effective dosage and increase by small, practical amount. That is the benefit of immediate release. That's the benefit of using it as an as-needed basis. Reassessing. Most of your traditional opioids like morphine and oxycodone, if it's in the oral route, you should be able to reassess because they'll reach steady state within about 24 hours. If total opioid dosage is greater than 50 morphine milligram equivalents per day, reassess pain function and treatment, increase frequency of follow-up, and this point we consider thinking about naloxone, which we'll talk about later. Avoid increasing opioid dosages to greater than 90 morphine milligram equivalents a day if escalating dosage requirements. Discuss other pain therapies. Consider working with the patient to taper opioids down or off. And then this is where a PCP practitioner should consider referring to a pain specialist. How much is this 50 or 90? So let's do some comparisons. 50 milligrams of hydrocodone, 10 milligrams of generic Norco, 10 Norco 5/325 or Vicodin 5/300, 33 milligrams of oxycodone, and 12 milligrams of methadone. Notice the difference in potencies. When we think about 90, it's 90 of the hydrocodone, 60 of the oxycodone, and 20 of the methadone. Remember, the key thing too is when we're switching from one opioid product to the other is that you can convert those morphine milligram equivalents by using the same opioid conversion chart. You will start to see, if you haven't already, prior authorization alerts for patients, especially if they have approached the 90 level or the physician's initially prescribing them above 50 and they've never been on an opioid therapy. If patient is already receiving a high dosage, offer established patients already the opportunity to reevaluate their continuous use, and due to the recent evidence, talk about the risks of overdose, and try to see if you can come up with a plan of using other alternatives and tapering down the opioid. Number 6, long-term opioid use often begins with the treatment of acute pain. When opioids are used for acute pain, clinicians should prescribe the lowest effective dose of immediate release, once again, should prescribe no greater quantity than the needed for the expected duration of pain severe enough to require opioids. 3 days or less will often be sufficient. More than 7 days will be rarely needed. And so when you're seeing day supplies from the ER, from dentist's office, this is the day supply we should be looking at. And we should send up a red flag if they're prescribing longer durations. When opioids are needed for acute pain, prescribe the lowest effective dose, less than 3 days as mentioned before, prescribe the amount matched expected duration of pain. Do not prescribe additional opioids just in case. Do not prescribe extended release, and reevaluate this patient if the pain continues longer than expected. Number 7, clinicians should evaluate benefits and harms with patients within 1 to 4 weeks of starting opioid therapy for chronic pain or of dose escalation. Clinicians should evaluate benefits and harms of continued therapy with patients every 3 months or more frequently. If the benefits do not outweigh the harms of continued opioid therapy, clinicians should optimize other therapies and work with patients to taper. Follow-up. We should be reevaluating, the clinicians should be reevaluating within 1 to 4 weeks of starting a long term therapy or dosage increase, and at least every 3 months or more frequently. At follow up, determine whether opioids continue to meet treatment goals, there are any common or serious adverse effects or early warning signs, benefits of opioids continue to outweigh the risks, and opioid dosage can be reduced. Tapering opioids. Work with patients to taper opioids down or off when no sustained clinical meaningful improvement in pain and function. We're getting above that 50 morphine milligram equivalence. Concurrent benzodiazepines that can't be tapered off, and therefore we increase the risk for side effects such as respiratory depression. Patient requests a dose reduction. Patient experiences an overdose. Taper slowly enough to minimize opioid withdrawal. The best way to do this is decrease by 10% per week. Look at the kinetics of the drug. Most drugs, go down in steady state after 4 to 5 half-lives. And so being conservative, there's nothing wrong with that. Assess appropriate expertise for tapering during pregnancy. Optimize non-opioid pain management and psychosocial support during the process. Assessing risk and addressing harms of opioid use. Recommendation 8 says, before starting and periodically during continuation of opioid therapy, clinicians should evaluate risk factors for opioid-related harms. Clinicians should incorporate into the management plan strategies to mitigate risk, include considering offering naloxone when the factors that increase risk for opioid overdose, such as history of substance use, higher opioid usage, and concurrent benzodiazepine use. Avoid prescribing opioids to patients with moderate or severe sleep disorders, breathing when possible. During pregnancy, carefully weigh risk and benefit with patients. Use additional caution with renal or hepatic insufficiency. Ensure treatment for depression. A lot of times patients are seeking pain due to they may have pseudopain due to severe depression. Consider offering naloxone, as we stated earlier. Recommendation 9. Clinicians should review the patient's history of controlled substance prescriptions using the state PDMP data to determine whether the patient receiving opioid dosages or dangerous combinations that puts him or her at risk. Clinicians should review this PDMP data when starting opioid therapy for chronic pain and periodically. And we know that, recently we have passed guidelines that we need to be reviewing these patients for patients willing to pay cash, patients that may be currently on a benzodiazepine. And pretty much, I know the website's not perfect, it's a little slow, but should have making sure there's some type of workflow in your policy of how you check that. I've seen some pain clinics actually check mark right off the script, PDMP was checked. And so having a standard documentation system, as a legal requirement may be something that you should think about in your pharmacy workflow. And I know physicians are trying to figure this out. Not all are perfect as others, but realizing that this is also a burden is now falling on the physicians. If prescriptions from multiple sources, high dosages, or dangerous combinations, discuss safety concerns with the patient. For patients receiving high total opioid dosages, consider tapering, consider offering naloxone. Consider opioid use disorder and discuss concerns with your patient. If you suspect your patient might be sharing or selling and not taking them, consider urine drug testing. And that's why a good clinician has a pain contract where they're already doing random urine testing. Do not dismiss patients from care. Use the opportunity to provide potential life-saving information and intervention. Some physicians just cut them off, worrying about legal liability. But that's the problem. A lot of these patients aren't seeking, abuse care. And sometimes it's easy to shrug them off, but sometimes there are ones that still can be saved, and having that conversation with them. And you may need to consider that, especially when maybe you catch somebody in your PDMP. What do you do? What is your policy? What are you thinking about? This might be something, this would be a good discussion during the talk. Live session at among yourselves, sharing with what are you doing in your workflow, what are you thinking about. Recommendation number 10: When prescribing opioids for chronic pain, clinicians should use urine drug testing before starting opioid therapy and consider it at least annually to assess prescribed medications. Using urine drug testing to assess, prescribe, be familiar with the testing panels. Don't test for substances that wouldn't affect patient management. Before ordering urine drug testing, explain to the patient that testing is intended to improve their safety. Explain expected results. Discuss unexpected results with local lab and patients. Verify unexpected, unexplained results. Do not dismiss patients for care based on urine drug testing. Another thing I think is very important with all this PDMPs checking is that you should have, because you're sending this off electronically at night, you should have somewhere in your system, if you haven't already, that you are checking every script maybe one more second time, especially the prescriber. It's very easy in most of our pharmacy systems to take an old script and just renew it, and saves us on typing and helps speed up workflow. However, if the patient maybe has changed prescribers and seeing somebody new, and somehow you accidentally put that old prescriber and that gets sent, that may have ramifications with that patient when they go see their prescriber, and that prescriber may be suspecting maybe they're shopping around because they put the wrong prescriber on. So it's real important that we're checking our day supplies, we're checking that. Some pharmacies also have incorporated when they allow a fill. Some have a policy of a 2-day rule, a 3-day rule. I know a lot of insurances have tightened when they're allowed refills, but maybe you have a standard refill, and that's how you build that trust and say to them, I know that you want to get this, but you should have plenty here, and our policy is 3-day rule or 2-day rule. Recommendation number 11. Clinicians should avoid prescribing opioid pain medication and benzos concurrently whenever possible. We know that the risks of this is that a lot of times benzos get prescribed because we're trying people with that have other psychotherapies such as anxiety, depression. But the problem when you coordinate and combine those together, you increase the risk for respiratory depression. And so if a clinician is using a benzo, it's better to try to use the most short-acting hydrophilic, like a lorazepam, if possible. The other thing is, remember generic soma, carcinopropital. Can't talk right now, sorry. Remember, that actually breaks down into mepobramate, which is another anxiety drug, and that can be life-threatening too. And so when we talk about non-pharmacological therapies, some of our muscle-skeletal relaxants we should actually avoid in combination too. Number 12, clinicians should offer arranged evidence-based treatment, usually medication-assisted treatment with buprenorphine or methadone in combination with behavioral therapies for patients with opioid use disorder. And this varies. Some, treatment plans believe no buprenorphine or methadone, go cold turkey. Others do that. And we probably all have our skepticism about using these agents and how we've seen them not used appropriately and sometimes abused also. If you suspect opioid use disorder, discuss with your patient, provide an opportunity to disclose concerns. This stands for us too. Especially, once again, what do you do when you capture somebody who's been your lifelong customer and you see that they've just been caught in trying to seek opioids? How do you handle that? Sometimes you may be able to turn that person around. Just throwing them out the door may not be the answer, and they're going to just keep on seeking and seeking. And so, every situation is different. How do you relay that to the physician? How do you discuss that professionally without losing the confidentiality of the patient? Assessing for opioid use disorder, if present, buprenorphine through an office-based buprenorphine treatment might be an option. Methadone too, obviously, or long-acting injectable formulations of naltrexone. These should be referred to the experts who do this, but maybe you come up with a list of ones that you've seen success stories in your area that when you're going to start referrals for patients. And it might be a great way to develop those relationships with pain clinics and opioid abuse disorder clinics. If you go to the CDC website, there's lots of great material, patient materials, lots of fact sheets, posters, social media, web bands to help educate our patients in knowing and understanding how this is a crisis and how physicians are prescribing this. You may also arrange a narcotic take-back day with the local with the state police. These are good community service things, and letting people in the community know that you are concerned about, you want to see people treated with pain properly, but you also want to make sure people are aware of what's going on and the abuse potential. So let's look at the different types of pain, distinguish between pharmacotherapy treatment for various types of pain, explain the pharmacology and pharmacotherapy treatment principles from the different classes of pain, and discuss the opioid epidemic. So, pain is an unpleasant sensory and an emotional experience that is associated with the actual or potential tissue damage described in such terms. Pain is, unfortunately, always subjective, and that's why it makes it very difficult to identify who needs pain, who really needs it, and possibly who's not really needing it. We have different types of pain. We have nociceptive pain, where we can have visceral pain that comes from our internal organs, somatic that can come from our muscles, tissues, and skin. Most of these are usually acute, and a lot of times these can be treated with NSAIDs, acetaminophen initially, and opioids are effective with these pains, but if we have to use opioids to reserve, we should be using them immediate release, short term, until, especially in tissue damage, until it's repaired, which can be anywhere around 6 weeks, 3 months. Neuropathic can be peripheral, can be central, can be due to a spinal cord injury, can be due to disease related, such as diabetes. It's usually chronic. Treatment options that are way better than opioids are anticonvulsants, SNRIs, specifically duloxetine, tricycline antidepressants, nerve blocks, and we should be reserving, if we're using opioids, methadone, buprenorphine, ketamine may offer better efficacy than opioids due to their NMDA antagonist effects. Now, we are going to talk about in the new drug therapy about the newer Belbuca for buprenorphine. Rules for the rational pain therapy. Obviously, we want to minimize the number of drugs, just like we talked about in the CDC guidelines. We want to think about alternatives. Start low and go slow. Titrate to effect. Educate patients. And the key, review regularly. Acute pain, pharmacologic management is the cornerstone. Multiple factors for drug choice based on pain intensity, type of pain, patient's preference. Normal, nociceptive, we can get away with non-opioids, opioids, local anesthetics, non-pharmacological, acute pain. So let's look at the management of acute pain. Pharmacological agents used to do this is our NSAIDs. However, we should be evaluating who should be on an NSAID. Obviously, we worry about patients that have renal impairment, patients that have uncontrolled high blood pressure, patients who have a risk of GI bleeds, patients who are already taking a prescription NSAID. Tylenol, obviously we worry about Tylenol overdose. We want to make sure that we don't definitely go over 4 grams. Some suggestions say definitely not over 3.2. And also the other thing that increases the risk for Tylenol toxicity is drinking more than 2 drinks per day. Local anesthetics, they work as counter irritants, the menthol and methyl salicylate, so they kind of trick our body to think about a cooling effect. Capsaicin comes from chili peppers. It tries to burn substance P, and lidocaine acts as a local anesthetic to numb the area, which can be good for types of neuralgias. And diclofenac can be good for osteoarthritis as a gel. And because it's available as a gel, less risk for the NSAID toxicities that we see systemically. If it's a muscle injury, using the old Rice method, rest for at least 24 to 48 hours, ice at least every 20 minutes for the first 24 hours, compression, some type of ACE bandage wrap, and elevating the area if it's like a lower ankle injury or wrist injury. Management of acute pain that is moderate to moderately severe acute pain is more likely to require opioids. Non-opioids often are combined with opioids to improve pain, such as acetaminophen, So you've got your generic Norco products, which is hydrocodone and acetaminophen, and your Percocet products. Both are C2s now, and both are combined with the lowest dose that's in them, 325. Important, once again, to counsel about risk for Tylenol toxicity. But once again, in these situations, non-pharmacological treatments such as applying heat or cold, usually after 48 hours, we go with heat. And if we do go with heat, we try to go with moist heat. Relaxation drills, electroanalgesia, like TENS units, may also help with this acute pain. Chronic non-cancer pain, treatment goals: diminishes suffering, including pain associated with emotional distress, restore physical, social, vocational, and recreational function, optimize health, including psychosocial and well-being, improve coping ability. Examples are arthritis, lower back pain, fibromyalgia, and peripheral neuropathy. And so, besides using drug therapy, they should be working with their specialist of how to deal with these pains. Maybe sometimes needing DME equipment for providing relief, such as canes, walkers, and sometimes different types of braces that might be needed. Obviously, for the management of non-cancer type of pains, when we think about neuropathic, we think about anticonvulsants and antidepressants, and the nociceptive, we're thinking about anti-inflammatories, opioids, or muscle relaxants. When we think about the management, obviously good non-pharmacological treatment, as I mentioned earlier, education, and treatment. The other thing, too, is some of our treatments have gone beyond what we do. And so, such as rheumatoid arthritis, instead of using NSAIDs or trying opioids, the better option is trying to talk to them about some of our newer specialty agents, like the tumor necrosis factor agents, like Humira and Enbrel, that help slow down the progression of the disease, which in turn can help with pain relief. So, let's look at the pain medications. You've probably attended numerous talks about pain and are familiar with this. We deal with this every day with our customers, with both OTC and prescription. Acetaminophen is our first trial. Its mechanism of action is not necessarily truly known, but we believe that it has an inhibition of prostaglandin synthesis. It's not great for traditional inflammation. But it will help not just as a drug for fever, but help with mild aches and pains. In fact, there is evidence of using, around the clock, anywhere from 650 to 975 milligrams of acetaminophen Q8 hours for the treatment of osteoarthritis pain. We do have to worry about hepatotoxicity, and we counsel patients to avoid drinking while taking Tylenol. NSAIDs, we know that they inhibit the arachidonic acid pathway by inhibiting the COX enzyme, and leads to the decreased production of prostaglandins. The uses of this is it does provide anti-inflammatory effects depending upon the dose of the NSAID or the potency of the NSAID, but it definitely also provides, just like Tylenol, analgesic and antipyretic. The biggest, because it affects prostaglandins, the non-COX-2 NSAIDs can put the person at increased risk for GI intolerance and ulcers. If they have to be on these drugs chronically, we think about adding maybe a proton pump inhibitor, which has been shown to decrease this. It can blockade of platelet aggregation, so if they're on a daily aspirin, especially like ibuprofen, we want to make sure we space it away at least 48 hours from the aspirin therapy. We know that it can affect kidneys, and so we should be monitoring their blood pressure and also checking their renal function periodically. Topicals. Topicals are the best because they have the least set of side effects, less chance of systemic absorption. We have over-the-counter our menthol, methyl salicylate, camphor type of products, which act as a counter irritant. And so what they do is they provide that cooling sensation along with pain relief by making the mind think of something different. Capsaicin, which for a person to use it, the best way is to counsel them that they have to apply it every day. It will burn initially because it's derived from hot peppers. But what it's doing is it'll eventually deplete substance P. And so for a person to use this, they can't just use this as a PRN basis. Key things too, if anybody that you know, make sure you wash your hands right after it. Don't touch your eyes areas. and it helps desensitize. And it can be good for neuropathic pain and even some osteoarthritic pain in the knees and the hips and the wrists. Other topicals, lidocaine. We can now get lidocaine at 4% OTC. A lot of times lidocaine patches aren't covered unless it's associated with neuralgia related to post-herpetic neuralgia due to shingles. But lidocaine is great for neuropathic pain, and we do also have the lidocaine 5% cream, which can help numb local areas. Another good topical is the topical NSAIDs, such as diclofenac, and it is often the first drug of choice for osteoarthritis-related pain. The nice thing about it is there is in the box a way to measure 2 grams versus 4 grams. 4 grams is for a larger area, and they rub that in, and you get the local pain relief effect, but you do not get the systemic effects. And this is especially important when we're dealing with elderly patients. Anticonvulsants, gabapentin and Lyrica are your classic ones. They modulate alpha 2 delta subunit of the calcium channels of the CNS. They're primarily peripheral neuropathy. Biggest thing is patients have to take these every day for them to work. The other biggest thing is they don't want to stop cold turkey, because even if they don't have a history of seizures, there is a risk for inducing a seizure. You slowly titrate patients on these because they can cause dizziness, nausea, peripheral edema. And Lyrica is considered a Schedule 4, but gabapentin has just as most potential abuse. And in taking in large doses, you can get a euphoric effect, and that is why Lyrica is controlled. Trying to avoid taking the evening dose right at bedtime, maybe 1 to 2 hours before bedtime, because these drugs, based on their stimulation, can cause sometimes insomnia. Antidepressants, not fully known how these medications work, but it seems to be working with norepinephrine especially. That's why we see the benefits of using duloxetine. Amitriptyline, nortriptyline, and doxepine have been studied. They do provide great relief. They are effective. However, we have to be careful due to their anticholinergic effects. Patients who have heart conditions, they should get an EKG because they can cause heart block and cause orthostatic hypotension. The better drugs that are better tolerated is duloxetine. Duloxetine is probably better than venlafaxine because you don't have to increase the dose significantly to get the effect. Venlafaxine, you usually have to get to about 150 to see the pain relief. Just be cautioned that they are contraindicated in severe renal function in elderly patients. Also, too, they should be slowly titrated up, and they can have really bad withdrawal effects, so they should be slowly titrated down if we're stopping these drugs. Opioids, obviously, we already talked about the universal precautions, the communications, the documentation, and the goal to reduce drug dependence early on. We know that they work at the mu, kappa, and delta receptors, and depending upon the receptors, is either seeing the analgesic relief and you're also seeing the side effect relief. So at the mu receptor, we're seeing respiratory depression. The kappa, we're seeing the dysphoria, psycho symptoms. And obviously the classic ADRs is nausea and vomiting. Chronic opioid use, we can see constipation, which a lot of times requires using a stimulant-like type of laxative, like Senna or bisacodyl, or some of the newer agents. We also can see some of the older agents like morphine having anticholinergic effects that can cause urinary retention. Your classic opioid types are codeine, hydrocodone, hydromorphone, morphine, oxycodone, oxymorphone, buprenorphine. It varies on patients. Remember, codeine breaks down to morphine. Some patients can't metabolize codeine, therefore it's not effective. Some patients respond better, and as we know, there's differences in potencies. If somebody has a true anaphylactic reaction to morphine derivatives, we need to think about other classes such as fentanyl, which obviously the downside of that is we cannot use it in fentanyl naive patients. Other options is methadone, and as we know, propoxyphene is no longer on the market. Other things we have to be careful with is a lot of our opioids are renally cleared, and so especially that's why starting low doses in elderly patients is important due to also they have an increase in sensitivity. Also, too, when we're trying to calculate and switch from one opioid to the other, we should be using the conversion factors. Also, taking into effect that when we do these conversions, it should not be a direct one-to-one. There is a cross tolerance. So when you convert, you should always lower that somewhere between 10 to 20%. So, the last part, let's discuss the opioid epidemic, review some case studies to determine our role as a pharmacist. We know that there's numerous deaths per year since 1999 in the overdose of opioids. And a lot of this stems from that in the late 90s, our big goal was to treat everybody's pain. And unfortunately, we tipped the pendulum to the other side. Nearly 2 million Americans aged 12 or older are either abused or were dependent upon prescription opioids as of 2014. And by 2012, in the Appalachian states, there was a study. There was enough opioid prescriptions written by doctors to outstrip the total population. So, what are some ways we can contribute? Well, one of the things here in the state of Pennsylvania, our physician general has developed is a naloxone standing order for the prevention. We know that opioid epidemic is occurring. We know that overdose is a risk, especially for patients seeing multiple doctors, patients seeing one doctor on high dose morphine milligram equivalents, patients seeing one doctor on low dose is very low risk. So, what does the standing order say? It was signed into law back in September of 2014. It allows first responders, including law enforcement, firefighters, EMS, the ability to administer naloxone when an overdose is suspected. Other individuals may obtain a prescription for naloxone. There's the Good Samaritan provision. So if a loved one is worried about somebody, they can actually now call 911 for that. In 2015, Governor Wolf stood with Physician General Dr. Rachel Levine as they signed a statewide standing order for naloxone. So this is a collaborative practice agreement. It is intended to ensure residents of PA at risk of experiencing an opioid-related overdose or eligible patients are able to obtain naloxone. Eligible persons, family members, friends, or other persons who are in position to assist a person at risk of experiencing opioid overdose. It's not intended for medical professional organizations with prescriptive authority. So this is allowing that somebody who feels that their loved one or their person they're close to is at risk could come in and acquire this naloxone with the standing order prescription. And like I said, it may be used for eligible persons to obtain naloxone from a pharmacy in the event they are unable to obtain naloxone prescription from their regular healthcare provider. As we know, naloxone is the current antidote to reverse opioids and safe and effective. First responders now use it, as I stated in the 2014 law. What are the signs and symptoms of overdose that if you would see them? Blue skin tinge, usually lips and fingertips show first, body very limp, face very pale, passing out, choking sounds or gurgling, snoring noise. Breathing is very slow and irregular. And this can happen in an instant. I remember seeing an opioid overdose accident when I was in my residency, and a gentleman sitting in his chair and just boom. It was a med-air nurse gave him an opioid too quick within the last time he received it and went out. And then I watched naloxone being administered and how he came back within seconds. Other strategies for reducing overdose, obviously we talked about the prescription monitoring program. There's the methadone and Suboxone treatment programs, and just good education. Why are people dying? Well, there's the fear of stigma associated with drug use, their failure to recognize the symptoms, and their fear that they don't want to get somebody in trouble. They don't want to get police involvement, and that's why that Good Samaritan law was passed. But you may also, as a pharmacist, encounter family members who ask you about these things. Obviously, we have to follow HIPAA, criteria, and we have to, use caution in this. But just providing educational pieces for them, letting them know where there's treatment centers, letting them know about the ability to obtain Narcan, and having these realistic discussions so these family members can have realistic discussions with their family members. And just to review naloxone, pharmacology administration, what happens in opioid overdose? Well, the opioid fits exactly at the receptor, and the brain has many receptors for opioids, Too much opioid fitting in too many receptors can slow and stop breathing, and that is basically what can happen and lead to respiratory failure. Naloxone is the opioid receptor antagonist at all receptors. It works to displace it, and it shows little to no agonist activity and shows little to no pharmacological effect in patients who have not received opioids. So you get a rapid withdrawal, agitation, tachycardia, pulmonary edema, nausea, vomiting, and seizures can occur after you administer the naloxone. The other thing is it's very short acting, and so you need to be calling 911 during the process of giving this. Naloxone reverses the clinical and toxic effects. However, it doesn't necessarily mean that, depending upon how much they take, that it couldn't occur again. It does reverse respiratory depression, hypertension, and sedation. And then patients can experience significant withdrawal symptoms after naloxone administration. And so, like I said, Narcan naloxone has a stronger affinity for the receptor site than the opioid. So, best way to administer can be through the nasal, the most rapid absorbed, and because there's no physical effect other than blocking the opioid. No adverse effects except for potential withdrawal, and no potential for abuse potential. So this is an example of a standard naloxone kit. There is the injection glass valve, and there is the atomizer, which would allow you to give this nasally. There's instructions to be able to put this together. And although there is the newer Narcan agent, it's fairly expensive, and a lot of insurance companies aren't covering this. And this one can be, although it's not super cheap, it actually is a lot cheaper and can be purchased if it's not covered by their insurance. There is still that argument, if it's not the person acquiring it but somebody else, could you get hit on an audit? To my knowledge, still right now, all the Medicaid plans and Medicaid managed care plans should be covering this. Actually, if you go to the PPA website, they have a great toolkit about naloxone, and they actually have a listing of some of the PA plans that are covering this. But once again, it's a case-by-case basis. Steps of preventing, the other thing that we could do as a pharmacist, maybe develop our own pain management program and basically market to physicians that instead of sending the prescription, give the prescription to the patient, they mail the hard copy, or the pharmacy picks up the hard copy. Hopefully, as more people pick on to electronic prescribing, this also helps enhance this process. And then possibly putting the medications into some type of tamper-resistant packaging to ensure adherence. Because a lot of times what will happen, patients, when they do pill counts, will do pill borrowing. That's why, too, if anybody does do multi-dose packaging, you'll see some physicians also prescribe odd amounts, and they do that on purpose so people can also borrow, packaging, bubble packing, or however it's packaged. And then the other thing, a pain management program, you actually could offer that you deliver it directly to their door versus them picking it up. Other options that you may consider in a pain management program is you could also offer in-services to local physician offices about what you know about the CDC guidelines, what you know about drug therapy, offer service for opioid conversion assessment, offer maybe developing treatment regimens for non-opioid pain options, help with formulary management, and maybe provide education to these patients either directly in the pharmacy or through some type of telemedicine program. And also helping, how do you deal with those complex patients, such as elderly, pediatric, patients with liver or renal impairment. So let's finish up by looking at a case. So this is a patient that I actually encountered a couple months ago, who actually is a patient of our pharmacy, and this patient was currently taking fentanyl, and they were taking they were taking actually 2 patches, and their total was 87 mics every 72 hours. So they were taking a 75 and a 12. And they also were taking Norco, 1 tablet every 4 hours is needed for pain. So the doctor wanted to switch them to morphine so that they could slowly start to taper this patient down. So what did we need to do? Well, we needed to calculate how much hydrocodone they were taking a day into oral morphine equivalents. We also needed to calculate their fentanyl. And what we found out, this patient was taking about 306 milligrams of oral morphine. And if I describe this patient, they're about 5'3", maybe weighed, 100 pounds if at best. And so just to think people can't handle tolerance on these agents, they can. But the biggest risk, this patient definitely was a high risk patient for opioid overdose. And so what we eventually did was we converted them over, but we also kind of went conservative, and we converted them over to about 150 milligrams of morphine for each. And we did that by instead of doing 25%, the physician wanted to go to 50%. And so our initial calculation actually was at 25% using the opioid conversion factors. So what did we get? Well, we found out that the recommended maintenance dose of morphine would be 75 milligrams Q12. So obviously 2 scripts would have had to have been written for that to occur, 16 to 15, and the breakthrough immediate release of 30 Q6. The final dose that the physician went more conservative than our recommendation. He went with morphine ER Q12, morphine IR. This actually still, because if you look at the morphine IR, all right, they are going to be at 120 milligrams of morphine milligram equivalent doses. This actually, even though this patient had been on fentanyl and the hydrocodone, the PBM fired back and required a prior authorization. And it didn't take long, but they had to call them up. And so sometimes patients, could get frustrated because now they're trying to wean off, but now this drug needs a prior auth. But the reason why I needed a prior auth was the doctor just had to call, document appropriately on the sheet, and it did work. And so the other thing we had to remember too is the fentanyl patch, not all the drug is out of the system. And so what we did was we told them to remove the fentanyl patches, discontinue the use of the hydrocodone, and after 12 hours of patch removal, start taking the immediate release morphine. After 48 hours of patch removal, then we began the extended release product. And so we kind of used caution for that. And then this came from our recommendation. We were recommending they could call the pharmacy if they had any questions. So we reviewed the guidelines. We reviewed some pearls with the pain medicines. But please look over the assessment questions. And I think for this discussion, when you guys meet live, a great thing to discuss about is how are you handling this? What are your workflow? How are you handling your documentation with the PDMP? All good things, because we as pharmacy can own this as being the ones to help our patients and help fight the epidemic. And it just gives good publicity to our pharmacy and showing how much we're part of the community. Thank you very much.